I've been told I have to project as though I'm trying to fill the whole room, so hopefully we'll see if this kind of works here. So thanks to Google for actually running this meeting. We're so pleased. We're a Boston-based company. This is probably the first meeting I've done in like 3 years in Boston, so that's actually a unique pleasure. So thank you very much for kind of doing it here. Let me give a bit of background about what Concert AI is. We've evolved quite a bit over the course of the last 3 years. The company was founded in 2018. We are the largest oncology intelligent network in the United States, and that's partially because of some of the work we've done with ASCO and the Cancer Link Network. A little bit more about that in a moment. We have reference grade multimodal RWD that we kind of consider to be high trust in the sense that we actually know its diversity, we know its origin, we know its representativeness, and we can place a context around that. It comes off of a base of about 8 million patient records. We have AI SaaS solutions for insights and for clinical trials. Today we're going to give you some of the background on the clinical trials, give a short demo on that as well. And we do oncology and radiology decision support solutions. And since this was referenced before, these are 510K software as a medical device, class 1 medical device solutions that are deployed. Our kind of provider-facing solutions are deployed in 1,900 centers in Europe, the United States, and Japan. And our life sciences solutions are deployed in 50 different companies. See if this, try one more. So inside our organization, AI now underpins everything. In fact, over the course of the last 18 months, we've replatformed everything in the entire company. It's all in a new data architecture. It's actually a new set of AI workflows that are optimized for multiple large language models, agentic AI, et cetera. One part of it is based around the Cancer Link Network. That was a group that we actually began working with ASCO, and we took responsibility for that starting in December of last year. The second part, as I noted before, is our multimodal data. And again, this covers just about every medical data type you can imagine, full exome, transcriptome, digital pathology, digital radiology, longitudinal clinical record, medical claims, and social determinants of health. And then there's the Cara AI Cloud itself. And then we have a new concept called Precision 360, which is not RWD delivered as a traditional data solution, but it is one that actually persists underneath a variety of different AI SaaS solutions. And then we have a series of AI SaaS applications or co-pilots, if you'd like to call them that. So AI in healthcare and oncology itself is actually super complicated to deploy. So you should think about us as we're not so much an analytics company as we try to build solutions that are actually done in practice and in clinical workflows or research workflows. So because of that, we've actually got to access broad data types, or we can't actually find the patient of interest. The other problem is the data don't not all necessarily neatly come into one single cloud environment. So medical images in particular are really large, and they sit oftentimes in prem-based PACS systems, and very little of that actually goes into cloud infrastructure. So we actually have to do an edge hybrid cloud model, or we can't actually execute any of our particular strategies. And then finally, workflows in any provider or research context are super complicated. So you actually have to kind of know where you are in the workflow, not add complexity to the workflow, but replace and consolidate things in the workflow, or actually you're making it more difficult at the end of the day. Cancer data itself, as you've kind of heard in the last session, did a great job. So some of this actually will probably save me a little bit of time. But cancer data itself is actually also really complicated. 70–80% of the concepts you care about are actually in the unstructured data, unstructured data being non-machine readable. And so because of that, you're actually having to process and get access to and put relevant context around and actually put it into a machine readable form if you want to even apply AI. In the work we're doing with millions of patients, we have billions of data points that we're actually trying to kind of run a variety of models and things within. So to do that today, we actually no longer use natural language processing technologies at all. In fact, the last set of our NLP solutions are probably being sunsetted here over the course of the next few weeks. Most of what we now do is series of large language models that are now kind of orchestrated and then they interact with agentic AI to do the work. Large language models really have some characteristics that make them quite superior to anything that we had actually used before. They can extract complex concepts, so NLP can handle 4 to 5. Large language models can handle 12, 13, 14, 15 to even kind of embody one particular concept. They actually get context, and that contextual awareness is critical to actually even understanding how you interpret a data element. And they're incredibly good at biomarkers and some other kind of characteristics. So right now, when we actually take those large language models, we're now actually taking them through a series of agents. So over the course of the last several months, some of you may or may not know what we do, but we have a workforce of about 1,100 or so people. About 400 of those, plus minus, actually do data curation and specialized software. They may have some pre-processing, but actually now we've kind of taken the workflow of actually expert curators. Most of these were oncology nurses that may have had 5 to 7 years of in-clinic experience, and now that's actually being done by an agent. And actually, we have an agent supervisor that actually reviews the work, and then we actually have a validation release agent that actually certifies and releases that and allows that to go into production. And if you're looking at the interaction between these, the supervisor speaks back to the curator agent in natural language reactions, giving them feedback on what they got right and what they got wrong. The corrections are made, and then that actually kind of moves on to the next phase. By the way, everything that I'm going through today, we actually have in production today. Give you an idea of what this looks like a little bit under the hood that allows us to ask a variety of questions. Some of these questions can support standard of care solutions, but they are actually also now supporting at scale some of the research solutions. So if I want to know what additional diagnostic tests can help ensure the selection of a best treatment that actually would even be reimbursable, you now could ask a question like that in virtual real time, and that's what we're trying to accomplish with these technologies, is real-time execution, not lagged execution, because that opens up additional use cases. We can actually talk about, is this patient eligible for a potential beneficial clinical trial? That's something we spend a lot of time on. And then through some of the work we're doing in CancerLink, we can identify what standard care treatment pathways should also be considered. In fact, we're actually that's an area that if we're here the next time, we'd actually present quite a bit of what we're doing on that one. So back in June, we presented some data on some of the results from that. That was probably some of the version of the technologies that we were deploying into first quarter, into second quarter, beginning of second quarter of this year. So far, we're actually technologies are about 3.3 times faster. This was as of June when we presented this at ASCO. 3 times faster than comparable expertise humans, and in fact we saw no differential in the identification of patients actually between the all-human high expertise and actually the model-based. Now, actually, we just got results 2 to 3 weeks ago, which will be published before, which actually indicates that for the sponsors we're working with, 25% of all the patients in their trial were identified actually with these technologies, but it only represented 5% of the clinical sites involved in the trial. And you can do your own kind of math about what the productivity differential is for kind of doing that as we kind of go forward. So we'll see if this kind of works. One of the things we've done so far is we've now put this together in an end-to-end suite. We kind of find that oftentimes the design of the clinical trials and the clinical studies themselves sometimes inhibit their ability to actually be executable. And in fact, anybody that does a lot of work in clinical research will know that there's a number of studies that sometimes accrue 0 or maybe 1 patient. And generally speaking, when we find trials that accrue no patients over the course of the year, they may even stop being supported and actually not even be within the range of what people are looking for. So we're trying to counsel and optimize and bring AI models to design the clinical trials, both then identify where those trials should be run and actually support the trial execution and automate the data collection around the trial. Here's a little bit of a, whoop, looks like it didn't actually want to run the video on that, so you don't get to see that. Sorry about that. Let me see if I can go back and try one more time. Well, it worked during the demo period. And I'm not going to try to describe it, and we'll figure out later why it actually didn't work here and worked during the demo period. But so what are we advancing on next in terms of what we're doing? Most of the work we're doing right now is geared towards phase 2b/3 trials and activities. So mid to late stage trials, almost all. Oh, he's going to, oh. Right. You have it with no volume, so you get my voiceover rather than the really elegant commentator that I had arranged for.
This is the Copilot to optimize the study design, ensuring maximum opportunity in enrolling the desired diverse patient cohorts in the study timeline. The clinical operations team uses the optimized study to select sites, focusing on areas with high patient volumes and diverse demographics. They use our advanced modeling tools to forecast enrollment, optimizing timelines and resources. Activated sites receive the study details through our system, which then automatically screens all registered patients. Clinical staff at each site conduct a final review of the automatically screened patients. They assess comprehensive data analysis provided by our system to confirm eligibility, ensuring the integrity and efficacy of the trial.
So I'm going to explain a little bit about what happened, just kind of given the kind of disjointed setup. So in the beginning, there is an actual design of the actual registrational trial that's actually going to be basically taken into the clinic. That actually creates the actual protocol in a protocol system of record that the sponsor actually uses. Behind that is a series of analyses supporting artifacts for that. That's the protocol that actually would be taken to the regulatory agency and kind of be used. The same tools that design that actually also underneath create the technology that then actually does the identification of those patients within the research site workflow. So essentially, we've recalibrated both mapping over from the trial design to the clinical informatics requirements, and those models are now run through either edge-based solutions or cloud-based solutions to do that. There's not a second step. So once that sponsor designs, it's a continuum of activity, and that can actually be deployed in the same form that it was designed actually for the patient to trial matching. That also sets up the same activities for doing the data collection on the other side of it. Going forward, we're actually moving into early phase trials. We're starting to do simulation on first-in-human in phase 1b/2a. We think that there's too much counting on serendipity. We look forward to working with a lot of the AI discovery firms on that. This is where we use a lot of our data and information to kind of predict. We have to actually use digital twins rather than actual population because and that's probably be its own long conversation on that. We're actually doing digital twin technology now as a pilot program with several oncology providers to do identification of treatments that may be most beneficial for that particular patient, and we line that up with pathways and guidelines. We're now taking a lot of what we're doing, and they're actually going up to enterprise-level grade solutions. Those start getting launched in January of this year. Some of the first parts of this will come out in December of this year, and then everything we're doing is going towards as close to zero latency as we can, which is we're working as possible to make sure that all the processing of all the data, all of our large language models is in close to real time, close to where the decisions are actually being made, which as far as we know, that's not really been achieved by anyone to date so far. So thank you very much. Appreciate the time.
Hi, everyone. Kareem Galil, co-founder and CEO of Mendel. Very fast, I'm going to explain what Mendel does, but I want to spend most of my talk today about hallucinations in healthcare. We're essentially an AI company that wants to make sense of electronic medical records. We ingest structured and unstructured data. We spit out a longitudinal patient journey that is ready for computer analytics. We don't like to be called an NLP company. We like to be called a reasoning company, and we see those two problems as being a little bit different in a sense of you can extract that the patient has fatigue, but it's a different story to understand that fatigue was a side effect, not a symptom, for example. And we do a lot of our work and effort on the second bucket of research. One of the things that we started back in 2016. Back then, transformers were just beginning, so we were super early on. We are not a wrapper of any of like the current technologies. We have invested a lot of research in the last few years to essentially, as I said, achieve one thing. Can we build an AI that have clinical common sense? And to understand more what I mean by that, Daniel Kahneman, in his very famous Think Fast and Slow book, described two brains, System 1 and System 2. System 1 is what you use when you're driving, for example. It's a very fast, intuitive system. When someone asks you 1 + 1, you respond 2. It's a very fast system. that is not capable of critical thinking. It is fast, but not capable of critical thinking, and is very error prone. Then you have system 2, which is your grounded brain that helps you answer more complicated questions. It's slower to operate, but it's less error prone, and it's capable of significantly higher levels of reasoning and critical thinking. When you look at the LLM technology, it is essentially system 1. And the idea of using an LLM-only architecture to achieve a human-level cognition of a medical record is just anti-gravity type of an idea. You need to have more than just an LLM component. You need to have system 1 and system 2, and that's the premise of our research. That's the premise of our talk today. To understand why that is an important thing, we have worked on a paper with UMass that kind of explains why reasoning and why an LLM-only approach is not the right ingredient for healthcare. If you look at this record, it basically described that the patient had edema. We basically used a couple of systems, ChatGPT 4.0 and Llama 3. And as you can see, the task was take the record and do summarization, and the summary was the patient has leg swelling. Obviously, edema is swelling of the tissues, but it can be anywhere. It can be in the legs. It's very common to be in the legs, but it's not the only place. Now, because it's a fast, intuitive system, it looks at a pattern. Most edemas are in the leg, hence the patient had the leg swelling, which is not true. That's not what happened in this patient. So that's an example of a hallucination. That's an example in one paragraph. If you look at a patient in cancer, we're looking about 1,000 pages. We're talking about hundreds of thousands of words. You can only expect the amount of hallucination that happens. And the outcome of that is worse trial matching, worse NCCN guideline treatments. It's a cascade of bad events from the minute you misunderstood the patient record, essentially. So we decided to work with a different with an outside institution to have a fair assessment of how do an LLM-only approach work in healthcare. This paper has been published, I think, a couple of months ago. Please feel free to go visit it. But essentially, what the paper did, it took a bunch of medical records and asked ChatGPT and Llama to basically do certain tasks, and we wanted to see where the hallucinations were happening. So where the hallucinations happening in patient information, patient history, symptoms, is it the medical instructions, is it the follow-up of the reasoning? But as you can see, we're not talking about few errors, we're talking about significant amount of errors that come out of these systems. How does that translate? And I think I've mentioned that in my talk an hour ago. In ASCO this year, there was an AI steering committee, and a group of oncologists were complaining that using a summarization LLM make them spend more time than just manually reading a patient record, because essentially the idea of hallucination and having to go back and view whether the AI was doing right or wrong. So I want to skip that. What do we do different at Mendel? What we basically do is we do use LLMs, because again, you want a brain that have two systems. So system 1 for us is an LLM that we have pre-trained on actual medical records. We looked at the curriculums where every other LLM is trained on. So if you don't know that, InfoWars, which is a big conspiracy theory website, has a lot of weird clinical information that is part of almost every LLM training that is out there. So what we did is we distilled our own curriculum of training data that we view as high quality actual clinical records, and we pre-trained our own LLM. But what we have done also above that is we have built a hypergraph. And essentially a hypergraph, think of a knowledge graph of knowledge graphs. And that hypergraph is able to understand the different relations between different entities into medicine. This is essentially a graph that understands a patient on Tagrisso is most probably a stage 4 patient. It's a graph that understands what is the relevance of a patient being on a chemotherapy. If you ask the system, show me patients who has never been on a cancer surgery, it understands that appendectomy is not a cancer surgery. And the innovation that we have done on that side is what we have seen is everyone is working with public ontologists like SNOMED, RxNorm, Loink, this very standard ontologists. And those ontologists were not built for AI, they were built for billing. So they were not built for the AI era of reasoning. They're not scalable. They have a lot of errors. B, it's not owned by one single entity that is like losing sleep at night to make sure that it is up to date. Third, medicine is a very hard domain to actually try to digitize in one specific ontology. Without digging in a lot of details of how we did that, if you think of the periodic table, few elements basically constitute every single compound that we know on the universe. Like nature was able to be abstracted in a periodic table. And what we have done is we have abstracted medicine in what you can think of as a periodic table. That periodic table is able to scale our hypergraph or our knowledge graph, which is a very grounded way for the LLM. What does that mean is once the LLM makes a prediction, it has to be filtered in the hypergraph for clinical validity and for it to be making common sense, essentially. How you translate that is if you think of the steps we take, we view every page and we start doing reasoning on it. Every single page of the patient record, we do reasoning on it. The outcome of that is then translated on a level of a patient, like rather than looking at a document, looking at the patient in totality. For example, and that's an example I've just mentioned, the system have made an inference that this patient is on Tagresso, but then later on had made an inference that it's a stage 1 patient. Are these two things common to be seen in the data or not? The pathologist mentioned that the patient is stage 4, the oncologist in the notes said the patient is stage 1. Like those type of conflicts we see once we step out from the document level to the patient level. And then after that, we are able to do reasoning actually on the cohorts of patients. For example, find me patients, again, who has never been on a cancer surgery. Now you need to go to every single journey and make an inference whether that was a cancer surgery or just a surgery. Now, those are 3 leaps of reasoning that you have to do. And as you may imagine, that can cost a lot of compute. That can be like theoretically possible, but practically impossible. And what I would like to show here, actually, I want to first show something around what I mean by text-based reasoning. Biopsy confirmed ovarian tumor consistent with breast primary. That basically means breast cancer patient that spread to an ovary. The down one, transvaginal ultrasound today showed a fetal heartbeat. That essentially means the patient is pregnant. So this is the type of reasoning and inferencing I'm talking about, is going beyond the explicit mentions to what that actually means for a physician reading those type of records. Now you want to do this on every page, then you want to do this on every patient, then you want to be able to do that on millions of patients. And you want to be able to do that with enough like scale, like you don't want to be paying $8 per patient in compute, you want to be paying $0.01 per patient in compute. And those are the technical problems that Mendel has been working on. To give that in context here, this is an example where we essentially took a cohort of patients and we asked a group of physicians how complex the patient data in there. Then we also computed how many documents it has. And then like we basically wanted to assess how complex a cohort of patient is from a document size and from a clinical perspective. And we wanted to see how a Mendel system would do versus a ChatGPT or a Llama trained on actual medical records. And you can see consistently we're able to find the correct right number of patients. And we're also able to do reasoning that is miles more advanced than an LLM-only approach. I want to explain also, like, those graphs are publicly available on the internet. I want to explain more what that means on the bench side. What that means on the bench side is, in those 1,000 patients that we have seen, we knew that some of them are not eligible for any trial that we fed into the system. We found ChatGPT and Llama always generating a number of patients for these trials because a generative system is incentivized to give you an answer even when the answer is 0. There is no patients in the cohort that were eligible. And those are the type of hallucinations and errors that you can avoid with a neurosymbolic system that couples a knowledge graph with LLMs. Finally, I want to share this case study that we have done with Quest Diagnostics, where essentially the task was how many colon cancer patients that did a biopsy last year that actually have a colon cancer. And when you use regex or LLMs only approach without type of reasoning, you may find 8,000 patients. When you applied the Mendel system, we found only 2,000 patients, and even worse, none of our 2,000 were even a subset of the 8,000. And that's like, obviously, like, we're not talking about slightly better answer, we're talking about completely two different answers. Hired a team of humans to essentially review every single patient and kind of make a judgment which system was correct. And the conclusion was actually the 2,000 patients that we found were the correct answer. So I want to make sure that we're quantifying the problem here. Hallucination is not, you get a slightly better answer or a slightly worse answer. It can be actually a correct versus completely incorrect type of an answer, and that's the work that we have been doing on. My time is over, so thank you so much for listening.
Hey there, my name is Jennifer Ford. I'm excited to talk to you today a little bit about a different direction than what we've been talking all day. All day we've been talking about the way that research is being enabled and the incredible things all of these different companies are doing to bring it into the hands of clinicians. I'm here from Meditech, which is an electronic health record, and I want to talk to you about how we're working on leading this space from the physician aspect of things and the clinicians and bringing all of this incredible work into your hands. I'm going to start with a story, but I also want to ask a question. Who here is quite familiar with pharmacogenomics? Okay, a lot of you. So where this began for me was a decade ago, a group of really forward-thinking executives at my company pulled me into a meeting on a Thursday afternoon and said, we want to enable pharmacogenomics so that when a provider places an order, we can get a pop-up to tell them they should be looking at a different drug or a drug that is different for the patient. And I was very young and ambitious, and I said, that sounds great, let's do it. They said, can you get that done in the next quarter? And I said, sure, I got this, no problem. So I went home and I Googled, what's pharmacogenomics? Now, I'm going to tell you a little bit about what I found, but this journey became much bigger over the past decade. One of the first things that I read was that 50% of the drugs that we prescribe don't actually help the patient. And when we think about what's going on in the healthcare system right now, the way we prescribe drugs, the way we're giving drugs, the point of this article was that it's because of genetic underlyings. And pharmacogenomics, in a sense, is this idea of each of us have genes, variants, that metabolize drugs a little bit differently than others. And what we know is that 99% of people have a gene variant that could affect a drug they're prescribed in their lifetime, but over 70% of us have at least 4 of those variants. And yet, every time we're prescribed an SSRI, opioids, clopidogrel, warfarin, we're not checked for these things, but also in oncology, there's a lot about warfarin. So when I learned this, what I did was I skipped down to my local medical school, which happened to be Harvard, and that was very helpful. And I trained myself up in genomics, and I started working with our organizations around the world to hear what was going on. And I talked to our customers in the US, I talked in Canada, but I also talked in South Africa, Pakistan, Nairobi, Australia, Dubai, Singapore. And what I heard was the same story from every clinician who was trying to work with genetic data in the electronic health record. And that was this: test ordering. They went to order a genetic test and they went out into a portal that was owned by the laboratory and spent a significant amount of time putting that information in, or they put in a miscellaneous test and an oncology nurse had to do that afterwards. They then received those tests back, and those PDFs that came back were full of information, but sometimes 50, even 100 pages long. And they were supposed to be scanned into an area of the chart that nobody could ever find again. Then it came time to select a therapy for the patient. Most oncologists, especially in the community space, were going with their first and second line normal therapy treatments. And we found today about how important it is to find that right treatment for your patient's cancer. And they were scanning through the PDFs looking for that information, but Those PDFs only provide therapeutic information and therapies based on that lab's genetic testing. But there's a lot of other genetic testing happening in a patient's lifetime. Then we had to try and find a clinical trial for a patient. I don't need to tell anybody in here how complicated that is. We've talked about that today. Forget the long-term managing of care, understanding your population, and never mind this fact that we're supposed to be working pharmacogenomic, which was the original question and ask of all of this into the system. That was just off the table. So I, along with a team of incredible people who are passionate and want to do the right thing for clinicians, put together a plan to change the way that this works in EHRs and our EHR first going forward. What we did is the following. We worked to develop ordering with all of the major laboratories in the United States, all of these genetic laboratories. We streamlined customer-defined screens and created something that doesn't seem groundbreaking, but testing ordering within the EHR. What we found, and this is actually being a little bit light, was that this saved 15 to 25 minutes per order at our organizations. Not only that, as the results came back, we created an area in the chart for the clinicians to be able to view this data. We know this data is complicated. We're actually storing a lot more of it in the background than what we display. But it was one place where they could go, where they could get access to their solid tumor testing. We can actually link the pathological reports right directly with the genetic testing that was done on the same specimen in order to be able to not hunt around when patients have extensive amounts of information. And then we started bringing that discrete data directly from the laboratories, which comes in an HL7 interface that we have developed and standardized, to display that, breaking down by germline and somatic, to the clinicians. Now that we had that discrete genetic data in the EHR, and what I want to note is that those charts and having the data available in the chart has actually saved clinicians 30 to 40 minutes of prep time per appointment in the oncology space because they no longer have to go hunt through and try and find those key variants. This is a big deal about what we're doing in the clinical space. But now that we have that discrete data, we can take it a step further. And what we can do is we can start recommending right in the chart to the oncologists and the oncology nurses and the clinicians so they don't have to be leaving the correct therapies to match for this patient that they should be looking at. The EHR has a wealth of data. We not only have now the genetic data and the genetic testing from the genetic counselor that might have happened 10 years ago, the pathologist and the genetic testing they might have done at NeoGenomics, the oncologist testing, all of that is married and harmonized together, along with the patient problems, along with the other demographic information. We can say this is the right therapy for this patient. And what we're researching right now is with clinicians having this data, will they actually change their prescribing techniques? Will they go here at the second line therapy instead of the third or the fourth when they start hunting for it? On top of that, we started working in finding clinical trials. And in that same area, we're able to actually start matching patients on all of that genetic data to clinical trials specifically for them. And this allows them to start that process a lot sooner. A lot of times this gets put on the paper that sits on the back door for weeks on end until somebody has time to search and try and find that right clinical trial for them. This is expediting that process. Now, with this, we can also put the organization's clinical trials at the top as well. And what we have found is that with our organization, who, by the way, was a large community hospital in Maryland that went live with this a few months ago, in the 10 weeks before going live, they matched 1 patient to their clinical trials. In the 2 weeks after, they had matched 4 patients to their clinical trials. So they are being able to find patients more quickly and accurately and provide them with information. And not only that, they can integrate through messaging within the EHR to talk to their clinical trials manager and say, these are the clinical trials we're interested in, and send them. This is a huge difference in this process that's cutting down on time, and we're very excited to see what some of those time savings are and how that affects the outcome for the patients. Managing patient care is also becoming easier because of these integrations. We're able to build registries and cohorts of patients saying, I want to find my patient that has a specific BRCA mutation, or building cohorts to see if it's acceptable, whether you want to bring on that clinical trial into your organization. Also, because we have all of this data stored, we can start to mine it out of the data repository and build analytics dashboards to really deep dive in, look at different statistics of race and measurements of your population. And we've seen some really, really cool things come out of this. It's just another example of some of the data that we can hold. And then lastly, but maybe not least, we also were able to integrate pharmacogenomics into the EHR. With this, we can, at the time of ordering, based on CPIC, Dutch, and FDA interactions, in this case, this patient's being ordered for tamoxifen, commonly given, but also with very well-known interactions with people with your genes, be able to say, pause, maybe you shouldn't be prescribing this medication, you should be looking at a different dose before the provider places the order. We have seen organizations in the community setting develop pharmacogenomics programs for their patients based off of this and actually open it up to their PCPs so that they can receive warnings when they go to order warfarin or clopidogrel, or the anesthesiologist decides to order a medication for a surgery. One of the last things I want to mention about pharmacogenomics is that we actually saw just 4 weeks ago one of the largest mental health organizations in Canada go live with pharmacogenomic testing for SSRIs. I know a little bit different than cancer, but what that entailed was actually the first known transfer of discrete genetic data from a Canadian reference lab to a Canadian site, which is a big deal. We have this in the States, we have this in Canada, and we are looking to move it globally as well. AI will support all of this in the background as we go further and as we move forward. We're looking at ways to leverage ambient listening to listen to the data that the oncologists, conversations they're having with the patient, and find even those more directed trials, weed them down in the background so that there's not such a long list. I'm just going to close out by saying this other quote that sticks with me and I think about often, that the advent of precision medicine entails change in every aspect. We've been talking about a lot of different aspects today at this conference, but one of the biggest that will make the biggest change is to get our frontline clinicians to start thinking about how to treat differently, when to pause, when to look for a different medication. And if we can continue as organizations to help streamline their processes and make the type of time savings and satisfaction that we're seeing out of tools like this, I do believe that's the first steps towards change. Thank you so much.
Well, look, I'd like to thank Google for their kind invitation for me to speak at this conference. No, I thought about it. I don't want to just get up here and, throw a bunch of slides and data and talk about just, specifically BPG. I want to just like kind of, take a step back. We're comfortably into the age of digitizing the world, right? We've digitized, arguably information with Google. We've digitized communication with Facebook and Instagram, et cetera. Transportation with Uber, and we're absolutely in the process of digitizing biology. Just listening today across the entire supply chain of information, from how do we have our first touch points with patients in clinical care? How do we follow patients? How do we think about drug discovery and development and clinical trials, pre-market access, commercialization? There's AI across the entire spectrum. So when we started here in 2009, our company is based in Boston. We're currently in Framingham, and we're about to move to Waltham. I used to have to say artificial intelligence. I used to have to explain what this is about. But really, if we just have a call point here, we're talking about math. in its simplest terms, it's math. And what are we really trying to do? We're trying to use mathematics and a higher order statistical methodologies to, one, understand patients, try to predict how diseases behave, and first of all, even understand disease. And then we got to put all that information in populations of patients, in different geographies, in cancer specifically, at different phases of cancer, early, late-stage cancers, refractory cancers, et cetera. And then how does a tumor microenvironment for all the docs in the room, how does that actually behave to chemotherapy or immunotherapy or radiation? So the reason why I say that is that because it's touched every single one of us in this room. We all have had a loved one or a friend, or in some cases, a personal touch point with cancer. And the last thing that anyone's thinking about on a hospital bed is AI. They're thinking about what the hell they're going to get, how are they going to get treated, who's going to treat them, how is it going to work. So I'm really excited about where we are as an industry, and I really think this is a timely conversation for Google to put this on. But I do want to level set that we do have to remember that what we're talking about here is human biology. Man, it's really hard. It's very, very complex stuff. I saw Jeff had a slide up there about complexity, and he was right. I think I talked through some of this, but what our team has done is essentially try to go back to biology. Instead of just generating hypotheses from public data, which, look, it works beautifully sometimes. But our thesis is, how about if we go back to patients and literally start the process of drug discovery and development by the acquisition of human tissues, human samples, biofluids, and clinical records, so that the predicate of our process is actually templated on the human being, on the biology itself, and then use mathematics. In our case, we concentrate on causal AI, on Bayesian systems, because Bayesian systems, Wall Street's used it for a long time to try to understand, patterns and non-obvious, behaviors, et cetera. But it's causal in nature, because, I'll get to a slide on correlation versus causation. But what we've done is really try to use this process with partners around the world, leading medical schools and hospitals in various geographies to attain samples, bring them into our laboratory, understand the layers of the biology, and then really start to perform drug discovery based on where the math is guiding us. So our AI system is almost like a biological flashlight to help us, help us focus in areas that of novel biology. So essentially, we've built over 100,000, clinically annotated samples here in Boston that are they're clinically annotated. They're multi-omic annotated. So we talk about multinodal data. So that's the gene, the proteins, the metabolites, the lipids. So essentially, all the components of biology that represents who we are in different slices of time. So and this bank has been populated with over 68 global relationships, working closely with the Department of Defense, other governments around the world, major medical schools and hospitals. We have over a 70,000 square foot, wet lab in Boston where, these tissues, they come in, and we do a mass expression of data on these tissues and samples. But then what we also do is recreate the environment. So, for example, in cancer, we're taking patient-derived cells, explants, organoids, and recapitulating what that environment is, and perturbing these systems and agonizing them in ways just like we would see in a cancer patient, and taking the multi-omics all over again. So you can imagine how much data is being created just on one patient. And essentially, in some cases, hundreds and thousands of patients, all of these data are subjected agnostically. So there's no governing hypothesis to begin. We're allowing the Bayesian statistics to essentially posit these hypotheses that we can then go back into the wet lab and do target discovery and development, et cetera. So I mentioned, we have really key relationships with the Defense Department on breast cancer, on prostate cancer. And through the pandemic, we learned the importance of understanding of biology, how speed was important. We have an exclusive agreement with the Oak Ridge National Labs where we have access to the Frontier computer, which is the world's fastest computer, I think, as of today. But it does exascale computing. So we're able to actually integrate our algorithms onto a supercompute capability. So there's live clusters ongoing and ported in from all parts of the world. So we've actually built a drug pipeline. Because at the end of the day, what our team's really interested in is a solution. So the process, the discovery, the math, the AI, et cetera, they're all amazing tools. But what we're focused on, if you think about age-related aggressive cancers like GBM and pancreatic cancers and other aggressive solid tumors, our focus has been, CNS diseases, so Parkinson's, Alzheimer's, aggressive solid tumors, and rare childhood inflammatory diseases. So, for example, I think this is the week of awareness for epidermolysis bullosa, where we're now planning for phase 2, 3 trials for EB. We've started an early access program to plan for a phase 3 in primary CoQ10 deficiency. These are rare childhood illnesses that are mitochondrially driven. The company is really, in building over 15 disease models in the past 12 years, we're able to look back at those 15 diseases and build ensembles and really query where is it in pathway biology are we seeing real pressure points in disease. And there's two areas. When we overlaid all 15 of our diseases, we overlaid thousands of patients from all over the world. We're seeing that the mitochondrial medicine and the mitochondrial drivers to certain cancers and neurological diseases are common. But we're also seeing that protein degradation pathways are very common. So the two areas of biology that we're building drugs around are in mitochondrial medicine and protein drug degradation. There's a lot of activity. Obviously, it's become. I think this is exciting that there are many companies in the space now that are emerging into early discovery and now a few in phase 2, and we're soon to be in phase 3. But there's a lot of expectations, and if we look back, and on average, it takes about approximately about $5 billion to get a drug approved over 10 to 15 years. And I think there's, ambitiously, a lot of practitioners in the space have said, look, we can go faster, we can do things cheaper. But the reality is that we're facing very complex elements, which is human biology. So I think certain call points, for example, along the axis of either nailing a better drug target or being able to predict a better, clinical trial, or being able to do some of the work, as presented from CONCERT. It's really important work. How do you design the trial the right way? How do you accrue the trial the right way? These are things that are very costly. But importantly, I still think for all my colleagues at Big Pharma, look, I said this before, and it was, I got a lot of slack for it, but it is the truth. No one here is going to go to bed tonight knowing that they created a drug and there's a patient being treated and it was approved by the FDA. We're not there yet. So it may take pharma, 10 to 12 years, and they may spend, $5 billion. But we've put in hundreds of billions of dollars already on AI and drug discovery. We're getting closer. There's still work to do. But at the end of the day, it's absolutely the drug that matters. So there's still a lot of collaboration and a lot of work to do around the actual biology and medicine. And I just want to also, it was more of a question than a statement. There's a lot of attention that's been given on generative AI and the use of public data sets. So either you can go AI first or biology first. We chose to go biology first because we wanted to start with the patient. But data quality is so important. Look, I only have a few more minutes. I think I may be out of time. But the key message that I wanted to get across is we have to think about the biology first when we're doing drug discovery. Data quality is not to be underestimated. So how do you acquire that sample? How do you process that sample? Not all public data sets are created equally. So these are things that we have to think about. And then importantly, we're dealing with diseases where the underlying biology is not fully elucidated. So generating hypotheses against hypotheses on priors, like we heard throughout the day, the garbage in, garbage out component. So allowing the data to generate hypotheses is I talked about the 15 disease models. So so why did we choose the causal AI model? I mean, here it's easy to pin and blame Facebook. If you look at the graph from 2006 to 2016 against the inflation in the Greek economy and Facebook users, one could argue, did Facebook have something to do with the Greek economy, or that poor cat that's essentially from an image perspective? It's easy to look at that and draw correlations, but it's really, really important to allow the data to allow us to test out causal models. And I think I'll just take a few more slides to talk about AI is an enabler. It's not a replacement. There's a lot of societal anxiety around employment, around replacement, around economics. What we found is to do this the right way, we absolutely are going to need clinicians. We need biologists. We need data scientists. But it has to be done as a community. So, I think the fear factor around these replacements, and I'll just end. I think there was one slide in the back. I'll skip this slide. There was one slide in the back on our success stories from our clinical trials. If you guys don't mind putting that up. I think that was the last slide, but maybe it's not. Oh, here you go. So, these are patients with, these are kids with epidermolysis bullosa. You see, what type of disease, we're dealing with here, using our process and guiding these drugs now close to being into phase 3. These are wounds that are unbearable in kids. So being able to have these types of results in 12 weeks, also our GBM study that's being, read out at the SNO meeting in late November. Being able to get from 0 to late phase 2B trials in a guided way by using these patient samples throughout our phase 1 trials, understanding the mechanism, choosing the right indications in a pan-cancer drug. It's not just randomly done. So we're now at a point where our platform and our process is guided a very late stage pipeline. So we look forward to the future, and we absolutely look forward to more collaboration. So thank you.
All right. Okay, good afternoon, everyone. My name is Enrique. I'm the VP of AI at Bullfrog. We are a tech-enabled drug discovery company, and I'm happy to share with you our platform where we're leveraging generative AI, causal AI, and large language models to accelerate the drug discovery process. Our platform, and I see my slides have been Googlified as well, which is awesome. Our platform has four core components, and it's multimodal in nature, and it's disease and data agnostic. We can tackle pretty much any type of biological or clinical data and create causal models that explain the order of influence of features as it pertains to a phenotype. There are 4 key components. We start with feature engineering. Oftentimes, there's a very difficult task where we have high dimensional data, and it's very difficult, particularly when it's compositional, to understand where is the information content and how do we leverage that to understand a phenotype. We use an ensemble machine learning process to go from millions of features to a couple of thousand that then allow us to proceed in an unsupervised fashion. The key differentiator here is that we are operating under the assumption that a sample's label isn't necessarily true and is at best an approximation of the actual ground truth of a particular sample, in our case patients, that may be a state that's completely undefined. And you'll see during 2 case studies around cancer and neuropsychiatry how this manifests in unique combinations of phenotypes and labels that are largely missed in discriminatory analysis. As an example, tumor versus normal. We take these features, we use generative AI for dimensionality reduction, and then we create graphical representations of this data. In these graphs, we then find clusters and tight communities of patients, and we go in and try to explain why is a particular sample found in that cluster. That set of features, we then use causal AI to create a structure that shows the flow of information and how important each feature is to ascertaining a sample into a cluster phenotype. Our causal detector networks start from generative AI dimensionality reduction, and so we go from this feature selection stage. In particular, we use a lot of omics data, where we have these millions of features. We then train probabilistic variational autoencoders and capture the latent space of those models. We use decoder layers that are probabilistic in nature rather than predicting the actual value of the sample to capture very powerful representations of the data. So we go from millions of features to a couple dozen that represent the structure and all the information of the content. After this, we proceed completely unsupervised. So the only point in step we use supervision is for feature selection. We then go unsupervised afterwards. We start with what process we call graph indexing, which is a bipartite graph that has full connectivity between discretized values of the latent space and each sample. To this graph, we apply a link prediction engine that then summarizes the connectivity between each sample in a very quantitative and powerful way. We use both combinations of graph neural networks as well as distance metrics between these graphs. These graphs are representative of the input data. Each of these dots here is a sample, and we then find clusters of samples within these graphs using clustering algorithms like click finding or trust counting. We think these are very powerful representations of the input data, and that these clusters, what we're observing, have unique combinations of phenotypes. We use the same ensemble machine learning process that we use for feature selection to find what explains membership in the cluster. And that oftentimes gives us gene sets. Oh, keep forgetting I have a clicker. These gene sets are very difficult to act on. You can take a functional enrichment approach, right, that's traditionally done in computational biology, that does provide useful context for a particular gene set, but doesn't really tell you what the flow of action or information is in the set. As an example showed here for one of the clusters that we have, we do functional enrichment for a gene set of explainable features for one of our clusters, and you get some very interesting pathways that are found in the clusters. But you don't really know the order of operations here or what you should go after, which is why we developed our causal gene regulatory networks. This is an example of the platform applied to lung adenocarcinoma and TCGA. We've done this for all the cancer data sets that are mostly out in the public domain, with a specific task at hand of doing tumor versus normal comparisons. This process goes from the millions of features for each of these, right? We have multimodal omics, we have methylation measurements, genotypes, and we get about 1,000 features from the feature selection process, after which we do unsupervised clustering. And we get a handful of clusters here for lung cancer. Each of these clusters is then tied to a causal gene regulatory network that we create, as shown on the right. The flow of information dependency in these gene regulatory networks goes from left to right. Genes that are found on the left are more likely to drive expression and the actual phenotype observed in the cluster than those that are found on the right. And how do we actually create these gene regulatory networks? And so we're using large-scale machine learning models to ascertain cross-feature importance between every feature that's in the data set. To these models, we also add all possible confounders and all possible covariates to create these adjacency matrices of feature importances. These matrices are by their own nature asymmetric, We leverage that asymmetry to then be able to apply directionality to each of the relationships between the features. This is highly scalable, so we can do this for thousands of genes in very short order. In this example, this gene regulatory network has more than 6 million machine learning models represented per node, and we run this in a couple minutes using batch execution, such as Google Batch. Once we have these gene regulatory networks, we have to figure out how to sort them. And so we also have to create a process to understand, once you have a causal directed gene regulatory network, what is the most important gene in that network? And we took a competitive modeling approach where we're counting how many times does a gene show up upstream or downstream of other genes in the model. This gives us a quantitative summary of the importance of a gene in that particular network. Genes that are most upstream of the causal network and also impact the expression of most of the network score very highly in our models. There's two aspects of this sorting, things that show up on the top and things that show up on the bottom. Things that are on the top are drivers of the network, and things that show up on the bottom are responders of the gene regulatory network. We've also done this in a neuropsychiatric data set outside of cancer. We have a very powerful data set from the Lieber Institute that is brain sequencing of postmortem brain tissues. These are 3,000 plus samples from 5 different key brain regions that have transcriptomic, genomic, and DNA methylation data that we've applied the same platform to find novel subgroups and targets within these conditions. And these clusters actually really show the necessity of not really treating the label of a sample as ground truth. These clusters that we're finding have unique combinations of phenotypes. In this case, it's because this is a neuropsychiatric data set. We developed a feature learning process that tried to discriminate between the conditions, proceeded in an unsupervised state afterwards, and are finding clusters that have combinations of these phenotypes. This cluster I'm highlighting here is from the dorsolateral prefrontal cortex brain graph that has strong enrichment for patients that are bipolar, protection for patients that are control, but also enrichment of patients that are schizophrenic. These types of groupings are just not possible if you compare these cohorts in a combinatorial way. And you can start hypothesizing as to why this is happening, right? Maybe these controls are not controls. Maybe they're undiagnosed. Maybe they're at risk of developing these conditions. And it allows the labels that exist to be diffuse. To round up this process, we've applied large language models to understand further the hypotheses that we are creating. We developed a model that we're calling AlgoLLM that is a competitive model to sort any arbitrary list of items. In our case, gene lists. Our gene lists are ranked by their causal implications into the cluster and how explainable they are to a feature. But surprisingly, that still leaves a ton of hypotheses. Even when we've discarded a tremendous amount from the causal modeling, there's still a lot to triage. And we're leveraging large language models to accelerate this process. The idea here is to take a list, break it up into a random subsample of pairs, and use a large language models to select the winner of a competition, where that competition is any arbitrary feature you'd like to do. In our case, we're very interested in the attractability of those genes as targets and how they're related to a condition, and so we use those type of terminology in our prompts. The outcome of this is very scalable, so we're using low-cost microqueries. We use a 2-tier agent system where, in the large case, we use very affordable models like Gemini Flash or GPT Mini, and then proceed, once we identify things that are highly competitive in this space, to upgrade the models into more advanced and more expensive language models. We're seeing very interesting results in our ability to rank these and how this complements the computational biology approach. Again, our goal is to go from not only generating computational biology hypothesis, but what happens after, which traditionally has been you go to a key opinion leader at this point, right? You have a ton of hypotheses, you go and request feedback, hey, what is druggable here? You maybe try to find a drug hunter or things like that. We think that can be accelerated with these language models by tweaking these prompts. This is very protected against hallucinations because everything here is a probability distribution. So we're doing this random subsampling is done at scale thousands of times. Each of the answers is forced to give a probability score that is obviously fake because it's a language model, but it actually takes a very nice probability distribution shape that we find is a perfect proxy for how confident the model is in the answer. We're seeing very good performance in leveraging this for ranking things like how likely a target is to be good for a particular indication. We've tested this with random sets, for example, spiking in positive controls into a random gene set, such as asking, how does these genes relate to type 2 diabetes and which one is the best target? We were very surprised to find that the top things were actually not the positive controls and were missing in the databases that we're using. So this is a very strong complement to knowledge graph approaches to fill the gaps that are there. And we're now taking a hybrid RAG approach where we're combining knowledge graph queries to add into our context. We go and pull PubMed articles using top K approaches, and we're also using foundation models with that context to give a very accurate answer as to how a gene relates to a particular query. In our case, if it's targetable. And on the right, you see the performance of these models. We're capturing most positive controls really effectively. This shouldn't be surprising because all we're doing is trying to find what's known in the literature in a cost-effective way without having to go to the main experts. And that's been very, very effective. The opposite answer to this question, right, which are things that show up at the bottom of this, we think are innovation spaces. So not necessarily would you discard things that show up on the top of this, things that are no understanding in the literature are high-value targets for innovations or things that aren't known. We've done this entire process in about 6 months with only 2 data scientists. This really showcases the current state of AI-enabled drug discovery. We are a very LLM-forward organization and use it in every aspect of our workflow. And so something like this would have taken 100 people 10 years ago and very large expenditures. We're doing it very cost effectively with all of these tools. We think this rounds up the process of going from input data to actionable hypotheses in a very short and automated way. Thank you for your time.
Good afternoon. My name is Santosh Dikshit. I represent Persistent Systems. First of all, grateful to Google, to Joe, to Bill, to Ryan, Allison for giving the opportunity, a lot of support. I think Sasha is somewhere here. Sasha, thanks for the initial invitation. I have only flown 15,000 miles to be in this conference, right? It's important, and I was jokingly telling Joe, this conference is creating buzz even in India. There are a lot of oncology groups that I'm part of, and they are talking about this conference. As a student of oncology and now AI, I think this is probably the best place to be. And I'm going to tell you a little bit about the work that Persistent does in this space. So Persistent is a global service provider. We are a listed company. We are based out of Pune, but our biggest presence is in North America. And where technology is at par, we are trying to differentiate by bringing a lot of domain capabilities in healthcare life sciences, which happens to be one of our largest business areas. And I'm going to tell you a little bit about how we are trying to verticalize and specialize in the area of oncology. And here we are collaborating a lot with Google. There has been some strategic partnership agreement recently agreed upon, and that's going to be the theme of my talk. Again, a lot of discussions have happened throughout the day. I'm preaching to the choir here. Oncology is a big problem. In fact, I chatted with Gemini a little bit in the morning, and I asked how many Nobel Prizes have gone to cancer research. I think the number is 36. Despite that, we haven't really made a progress where we can say with pinpoint accuracy that we can treat a cancer patient with the help of technology, right? And the problems are many. In today's world, we are looking at there is a data explosion, but the data explosion also brings in a lot of variability, inter-observer variability in treatment, tremendous amount of explosion of data. And how do we solve this problem, right, in this space? So what we are looking at is a scenario in clinical reality. If you look at your left-hand side here, you will see the amount of data that a typical clinician or a scientist will see as part of your clinical repository. And in the central column, you will see the mind map of a decision maker, right? You have to literally take decisions in few minutes, if not seconds. And then there is no margin for error in those decision making, right? So that means we have to really be absolutely solid about what we are saying. And this is a space where we are already talking about tremendous use of technology. And I'm going to demonstrate to you what persistent things are our way of looking at leveraging the Gen AI services. So before I get into my demonstrations for these solutions, I want to set the stage here. I want to sort of track the journey of a hypothetical patient, let's say Hari Singh, and I want to tell you the story of how Gen AI can help Hari Singh and the caregivers to handle his case at different levels. So one is clinical record summarization. The second is diagnosis with imaging and even some genomics. The third is how can we automate the process of report generation. And these are real problems, I think we have heard. The problems are physician burnout. The problems are slow rate of delivery of reports, non-objective decision making, sometimes that can result into medical errors. And we are trying to address use of technology to minimize these errors. Disclaimer, these are still assistive technologies. Nowhere we are trying to obviate the human experts. I'm going to start showing some demos, but I'm also going to take a pause in between to demonstrate or to talk a little bit about these concepts. So prior to that, I want to acknowledge Google Healthcare AI Group. I think Jason is here, Rory Pilgrim, Alexander Secular. They have given us access to some core technologies from Google Research, and we have created some accelerators around it. So let's look at the situation where Hari Singh is suspected to have some lung abnormality, and he undergoes screening first, right? So we are going to look at screening, diagnosis, and evidence-based medicine as 3 pillars of the treatment. And I think when you talk about technology, yeah. Thank you.
Hello, everyone. We from Persistent Systems are introducing CanImagine, a Google-powered Gen AI-enabled platform for early detection of lung cancer via improvement in chest X-ray screening protocol. WHO Globocan estimates lung cancer as the leading cause of mortality globally. Higher prevalence is attributed to smoking and pollution, lack of awareness, shortage of radiologists, and inefficient screening programs. Our CanImagine platform is designed to overcome these challenges by leveraging Google's ML embedding models in Gen AI technology. Imagine 57-year-old Hari Singh visiting hospital to seek medical advice for his respiratory problems. With the EHR console, the doctor can either record or upload a pre-recorded voice note. Gemini's multilingual tool facilitates generation of electronic health record from an Indic language voice note validated by the doctor. The EHR dashboard displays medical details of Hari Singh and an AI-generated summary in multiple languages. Then the EHR similarity check tool compares available EHRs from hospital repository to predict the lung cancer risk. Then the doctor advises Hari Singh to undergo a preliminary screening with the chest X-ray. Now the radiologist uploads the digital chest X-ray image to the radiology console. It identifies abnormalities suspicious of lung cancer using a deep learning faster RCNN model integrated with GradCam layer, represented by bounding box and heat map. Further, the radiologist generates medically descriptive response using a fine-tuned Google Polygemma model. A rigorous fine-tuning process included use of annotated NIH chest X-ray dataset, 13 dataset versions, 19 model iterations, and expert validation. This fine-tuning resulted in 70% more accuracy than the base Polygemma model. Additionally, Gemini model summarizes collective responses generated by upstream ML and Gen AI models. The radiology console also identifies similar chest X-ray images from available repository using Google's Foundation model. Comparative image analysis with Gemini model enables radiologists with improved and objective decision-making. Radiologists can communicate with smart AI assistant via speech or text prompts to describe the chest X-ray image in medical vocabulary. Finally, radiologist generates an editable draft report, later converted to final standard report of Hari Singh with Gemini-enabled key entity extraction. In summary, our CanImagine can smartly utilize scalable Google infrastructure with multiple AI services and tools to accelerate medical consultation, improve second opinion process, increase speed and accuracy of analysis, and expedite automated reporting. Powered by Google's AI technology, CanImagine can be implemented in chest X-ray screening protocols for early detection of lung cancer with significant improvement in access, efficiency, accuracy, and affordability.
I'll keep moving. So let's say we have highly suspicious imaging data, and now there is an image-guided biopsy, and now we move to pathology. Let's see what we have done in pathology. Can we please go to the next slide? Yeah. No, one more slide back.
Generating actionable insights from large.
I think I'm pressing it twice. Can the console please play the video? Yes, thank you. Yeah, thank you.
Introducing Empathy, an end-to-end automated workbench designed to analyze digital pathology images for the detection of cancer. Powered by optimized embedding models and generative AI technology, our smart workbench assists oncopathology professionals by significantly improving accuracy in cancer diagnostics. Imagine a patient is advised image-guided biopsy of a tissue highly suspicious of cancerous growth. The pathology technician processes the tissue sample, generates a digital pathology scan of the whole slide image with histopathology features, which is divided into smaller chunks. These chunks are passed through high-quality embedding model for extracting abnormal features, which are then categorized as cancer versus non-cancer with a classifier linear probe. On this whole slide image, the area highlighted in green indicate cancerous lesions. Upon clicking on the individual grid, the zoomed-in version of the chunk of the whole slide image is presented along with similar chunks. Such similar chunks are derived from a vector database by minimizing the vector distance between the embeddings, thereby increasing the cosine similarity. By highlighting similar areas, this special feature increases the diagnostic capabilities of the pathology workbench. Our smart AI assistant analyzes the cancerous chunk with a large multimodal model and describes oncopathological features that confirm cancer diagnosis. This informative content can be exported to generate the editable draft report for authentication by the pathologist. For this task, the Smart Report Builder feature of Empathy helps pathologists convert the draft report into a standardized template using natural language processing. It extracts key medical entities and segregates them according to labels, allowing pathologists to modify suggested entities and manually add additional ones as needed. This tool also allows the pathologist to edit the generated pathology report before mailing and downloading it. The final cancer diagnosis report is reviewed by a health insurance claims officer to check eligibility for reimbursement. The officer uploads the report to our ClaimsMate tool, which summarizes the report in a simplified and short format. The disease description is converted to medical codes and further cross-matched with CPT codes for claims intelligence. If both codes match, insurance claim is validated. ClaimsMate expedites claims processing, improves compliance, reduces disputes, and enhancing patient satisfaction. In conclusion, our Empathy workbench, powered by embedding models, LMM, and NLP, enables pathology professionals to accelerate cancer diagnosis, report generation, and insurance claims that ultimately helps the cancer patients and caregivers.
And now the story moves into treatment, evidence-based medicine, where you have to take objective decisions. And here we have constructed an interactive knowledge graph, and let's see how that works. Console, can you please play the next slide and the video? I need help from the console in moving. I think this is not working. Can somebody play the next slide and the video? This is not working. Okay. Yeah.
Generating actionable insights from large, complex, and heterogeneous biomedical data sets is a big challenge for the biopharma industry. AI-powered data analytics using knowledge graphs has proved to be a game changer to overcome this challenge. A knowledge graph comprises of knowledge base that uses graph database technology with graph-structured data model to integrate multiple data sets. In today's era of precision oncology, oncoclinicians depend on objective evidence obtained from various tests for life-saving clinical decisions. We have created OmniKG, a cutting-edge knowledge graph platform for evidence-based medicine practice in precision oncology. In OmniKG, we have integrated well-curated, public databases with molecular and clinical pharmacology profiles of anti-cancer drugs. Then, we applied AI tools to enable data analytics for generating clinical insights. We demonstrate the utility of OmniKG in multidisciplinary tumor board setting for evidence-based clinical management of an advanced stage lung cancer patient. This patient has not responded to conventional cancer chemotherapy drugs. Hence, the oncologists would like to apply evidence-based precision oncology algorithms for choosing alternative drugs. Let us understand OmniKG workflows and features. By entering patients' clinical data, OmniKG generates a disease-specific knowledge graph instantly. OmniKG now displays complex relationships between various nodes, namely disease, organ, gene, variant, along with efficacy and toxicity of cancer drugs. OmniKG indicates that pemetrexed, a potent anti-cancer drug, has clinically favorable evidence to justify its use in lung cancer therapy. For example, Level B evidence from clinical trials confirms significant efficacy, and Class 3 evidence from FDA DILI database indicates lower liver toxicity. Using ToxaBuddy, a generative AI-powered virtual assistant tool, OmniKG searches all integrated databases in real time and identifies multiple drugs with favorable clinical attributes. Using AI-powered natural language processing, OmniKG compares pemetrexed with other anti-cancer drugs by extracting key information from their respective FDA-approved labels. Finally, using all objective evidence from OmniKG, oncologists from tumor board arrive at a consensus recommendation to initiate pemetrexed therapy for the lung cancer patient. OmniKG provides time and cost advantage to oncologists for accurate decision-making that will ultimately save the patient's life. Persistent Systems has a strong track record in AI-powered knowledge graphs applications for biopharma industry. Let us help you apply our expertise to overcome your challenges in big data analytics for biomedical datasets.
So my time is up. I'll quickly end in 30 seconds. We have just shown you the typical journey of a cancer patient. I mean, there is a lot more that we can do here, but this is the art of the possible. Persistent is also significantly investing in oncology R&D, and we have identified a few vectors where we see tremendous uptake in the industry: genomics, imaging, knowledge graphs, a lot of preclinical research. We are working to create an AlphaFold workbench with bringing a lot of technologies. Clinical record summarization, trial matching, very important, and real-world evidence, and individualized monitoring. For example, in liquid biopsy, MRD monitoring is becoming a major biomarker, and we are trying to see if we can create biomarker longitudinal stamping of biomarkers with the help of these technologies. Sometimes we do get a pat on the back from Google. Our team has been consistently winning some innovation awards from Google for the last 1.5 years. These awards are important because in a hackathon mode, we can create fast solutions with a lot of open source data. But the innovation index of this is, let's say, at 1x. But when I really take a real life data, the innovation index goes up. So we are very happy to work with any one of you if there is an interest. And lastly, big thanks to a lot of collaborators from Google. We will continue on this pathway. And at the same time, if you have any interest, I'm happy to take on questions further. Thank you for the opportunity.
Thanks so much for having us here, and I'm excited to be in a room with so many people who are interested in AI and oncology. It's obviously such an important application of cutting-edge technologies is treating patients with cancer and advancing the development of therapeutics. So a little bit about Medable. We have been working on clinical trials since I founded the company back in 2015. I was a physician scientist at Stanford and really working at the kind of looking at rare disease and trying to understand how we could apply off-label drugs to these orphan diseases, specifically in the autoimmune space. And I was not only researching rare disease, but I was researching rare disease in twin pairs. So, facing this incredible challenge of finding patients and then being able to connect with them when we found these rare twin pairs, which could be really anywhere in the world. And of course, being in the heart of Silicon Valley, seeing companies who are doing things like building technology to, deliver food to their house or hail cars and internet search, I thought, hey, this is a very important problem to solve with technology. Let's build a technology bridge between patients all over the world and be able to provide access to clinical research for these patients leveraging technology. So that was back in 2015. A lot of things have changed. This went from an idea to now a company that is hundreds of people working every day to solve this problem of clinical trial access and participation. Our company has now conducted over 400 clinical trials. We work with the largest pharmaceutical companies in the world to bring this digital platform to participants and patients. And we've actually shown through our research with the Tufts Center for Drug Development that we're improving the diversity of patients who are participating in clinical research, which is one of the massive challenges that we face, both from a scientific and an ethical perspective. So, I think it's just so exciting when we look at the applications of AI to areas like drug discovery. And, I think, in silico showed today that now they're identifying molecules that are validated in 30 days. I would say that if we look at what we need to do to leverage this moment in time to cure disease, the clinical trial is actually the bottleneck. It's probably a bigger challenge, actually, than the drug discovery. If you look at what it takes to actually get these therapies into human trials, the complexity of the human trials, the level of noise when you're doing this globally in a world where we're doing this in sites in all different countries and in all different languages, the clinical trial remains the bottleneck. And the evidence for that really is that over the last 15 years, while drug discovery has radically evolved, we still have the same number of drugs approved per year, which is roughly 50. And what that really says is that technology has not been leveraged to solve the clinical trial bottleneck. And our goal at Medable is to 10x the number of drugs approved a year, going from 50 to 500, taking the timeline to actually bringing the cures for the 10,000 human diseases from 200 years to 20 years. And we think that AI is actually the pivotal technology inflection point to provide this level of step function change. We're already seeing progress in some of the core areas that impede clinical trials when we apply AI. So one of the areas is, how do we actually measure the efficacy of the drug? And for those who are not close to this problem, it might surprise you to know that the way we measure drug efficacy in some cases really hasn't changed in almost 20 years. We still sometimes have patients go out and walk for 6 minutes and measure how far they can go and use that measure across a wide variety of diseases. We're now leveraging digital measures to improve the sensitivity and specificity, which actually enables us to reduce the number of patients in the trials and really accelerate the trials. So AI can actually be applied to improve the measurement of efficacy and actually have an earlier read on efficacy. Additionally, we're using AI around how we measure. Rather than having patients input data every day or have to provide a lot of burden to patients, we can actually measure the physiology passively and then apply AI to understand critical inflection points in the physiology. And finally, around patient burden. People who aren't close to clinical trials may not realize we're literally asking patients to do hundreds and hundreds of things over a timeline of years. How do we reduce this burden while also improving the adherence to clinical trials? And as we leverage AI to really engage with patients on an intelligent basis, we can minimize the burden for patients while actually activating patients at critical moments in the clinical trial process. So one of the areas that we've worked on this year is really, how do you get clinical trials into clinics and in patients' hands faster? just to give you a quick view of the problem, a clinical trial protocol is literally about a 300 to 400 page document. It will describe complex workflows that are basically activities patients need to do, activities doctors need to do, and there's a lot of dependencies between these workflows. So in the industry, it takes about 4 months to get this technology configured and launched and live across in some cases, over 20 countries in 60 languages that this is going to be deployed in. And this is actually one of the active bottlenecks to starting a clinical trial is getting that technology configured against that complexity and out into the real world for patients to use. If we're going to go from 50 drugs a year to 500, we have to be able to launch clinical trials faster. The complexity around this is exponential, and our opportunity to apply AI is one of the massive levers in bringing the timelines down and bringing the cost down. So again, 4 months may not seem like a lot, but actually in the face of many clinical trials running in parallel and a very competitive market where some of these sites are already enrolling patients in clinical trials with maybe competing assets, or you have patients who are actually living with a disease like pancreatic cancer or glioblastoma multiforme, that window really matters. They may not be eligible for that clinical trial in a matter of days, much less months. So we have been working with our Google infrastructure and across our stack to fully automate and embed AI in the process of getting a clinical trial solution into the hands of patients and doctors. And it's been just a fascinating and amazing process where we've been able to actually take something from 4 months down to fewer than 4 hours. And the way that we're actually doing that is by using LLMs to parse the input documents, which are quite a wide variety of documents. We then use our own ontology called Rosetta, which then harmonizes that clinical trial terminology with our own system language and semantic layer. We take the schedule of assessments, which is essentially describing all of the workflows in the clinical trial, and we create a knowledge graph from that. And then we use essentially a combination of graph, RAG, and ground agents to fully configure the study. This now is enabling the creation of these assessments, which we're showing here. This, crazy enough, used to take weeks. These are also then translated using AI and fully launched, and the testing is automated, and we're using essentially knowledge-verified, knowledge-validated testing where the knowledge graph is a reference point for our LLM to validate the full build. And so kind of soup to nuts, this used to be a highly manual process. We were not unique in the manual effort involved. I would say we were pretty far ahead of the pack in terms of leveraging cloud and mobile and a number of really important infrastructure capabilities. But we have now aggressively deployed LLMs and knowledge graphs and agents to make this something that is giving our customers the competitive edge. And the most exciting thing has been, hearing from our customers that they are able to now get patients into clinical trials earlier. And again, in many cases, these patients wouldn't be eligible if there had been a week or multiple weeks delay because their clinical circumstances change fairly radically. So to know that these technologies are really improving the lives of patients and facilitating patients to be enrolled who were otherwise unable to get in, I think is just so exciting. I would say, I think we're all really at the tip of the iceberg of what's possible, and we're seeing a tremendous amount of potential from graph neural networks and graph embeddings as really technologies that can not only ground LLMs, but then can also provide a lot of contextual predictive capabilities. So we're now looking at going upstream to be able to provide more optimization capabilities and technologies for our customers, who in some cases are running hundreds of clinical trials on our platform. and being able to understand from the data and the existing trials how to optimize and how to make and take action very quickly through the combination of knowledge graphs, LLMs, and then agents that can actually go out and reach out to a site maybe in Milan who is waiting for this one patient to come in 2 days and needs to know that if you enroll this patient, you're actually at the threshold for enrollment for the trial. So really exciting times. Just a fun announcement today is we launched our partnership with Google. So we're now on the Google Cloud Marketplace. So I think we're one of the first and probably only SaaS solutions in clinical, digital clinical trials. So you can actually launch the Medable platform seamlessly into your Google ecosystem. And this is so transformative for anyone in pharma who has study teams who, without an approach like this, are working day in and day out on legacy ground-up builds of these technologies. I think this is really a game changer and will enable patients to get into clinical trials faster. So thank you so much for your time. Check us out on the Google Marketplace. We're over there, Medable, and I have to say we have the best swag in the house. Sorry for everyone else, but we do have amazing hoodies, beanies, and I think coffee mugs. So come say hi.
Okay, let us, in real life humans, talk about metahumans and what they can do for our patients. So I'd like to tie this back to something Dr. Hood said at the start of the day today when he talked about the 4 Ps of transforming healthcare, and particularly that last P of participation. So participation is the act of activating our patients, educating them, giving them tools so they're not just passive recipients of the sick care system, but they're proactive drivers of that transformation to wellness that Dr. Hood talked about. But participation is hard. It's really, really hard. In fact, I would submit that changing human behavior like that is the hardest problem in the known universe. I mean, forget scaling LLMs or grand unified theory, or in my case, conversing with a screenager, right? These are really, really hard problems. So we had the benefit of spending several years in a very large community running a series of experiments to see what we could do to help people change their health behaviors. And there were really 3 major outcomes of that, and I'll talk about 2 of them right now. The first was that pure tech, really didn't move the needle. Maybe for the intelligentsia, the super activated, but for most people, it just didn't have a lasting impact. But what mattered, what did move the needle, is what I call the mom effect. When technology didn't feel like technology, but it felt like mom, it felt like there was a human connection there. There was enduring compassion and empathy, that we celebrated wins together, we commiserated in losses. Those things moved the needle. So we've been on this almost half a decade journey trying to find technologies that can kind of emulate that effect, that mom effect, because unfortunately mom's not scalable, right? She can't be omnipresent. And I shouldn't just pick on moms. It's dads, it's friends, it's your extended family. So we were watching the deep fake technologies evolve, and initially, like probably most of you, with great trepidation, but also with a sense of excitement that maybe this could be a scalable human interaction that would help people change their health behaviors. And then the second thing was when the generative AI technologies got to the point where they could almost pass the Turing test. Marrying these 2 things together felt like it would give us the power to change health behaviors. So that was kind of the genesis of this. I'm going to show you Q, a metahuman, here in a second, but I just wanted to say that this is a technology that we're actually rolling out in an international smart city. This is actually the first healthcare system that's been built from the ground up with cognitive AI in mind. It's literally post-EMR. And in fact, we did a bunch of estimates for them about the number of clinicians and beds and support staff that they were going to need. And they came back and lopped 30% of that off and said that's going to be the AI dividend. So they're really counting on technologies like these metahumans to help engage patients, help them move up that activation curve. So this is Q. It was really interesting. We've rolled out a bunch of different personalities and done a bunch of A/B testing. And one of the humans that we based this on, actually we lost the license rights to use that person. And it was amazing the reaction, the disappointment, the disillusion that people had by losing their favorite metahuman. That's when we knew that there's some power to this. So let me give you a sample.
Good morning, Patrick. Do you have a minute? I've noticed your recent fatigue, and I think I might know what's behind it.
Yeah, I'd love to hear what you're thinking. I'd rather sit down, though, so I'll meet you in the living room.
Patrick, I've noticed that you haven't been sleeping well, your step count is down, and your respiratory rate has been higher than usual. You just haven't seemed like your energetic self lately. Given your history of asthma and the most recent sandstorms, I'm wondering if you might be having an asthma flare.
You know, I hadn't thought of that, but it's usually a whole lot worse.
I think we might be catching it early. Can you please grab the spirometer? It's in the orange home health kit in your closet.
How do I use this thing?
It's super easy.
Okay, so that's just a short sampling of it. It had to be a video for logistics reasons, but if any of you would like to see a metahuman in action live, let us know. We'll demo it for you. There's a couple key things about metahumans. The first is half of the people are really excited to try this, and half of people are very wary and skeptical. And it seems to be very similar to, I don't know about you guys, but the first time I heard about Airbnb or Uber, it was just a really foreign concept to go sleep in somebody else's house or ride in their car. And I think that uncanny initial thing, you get really used to it after a while. And there are times when it's just much more efficient to talk to a metahuman than it is to try and get a super busy clinician on the line to get educated. Basically, we're finding anywhere where a clinician is repeating themselves in a low acuity setting is a great place for a metahuman to intervene. But in terms of permission structure, this always has to be opt-in. We're not forcing this on anybody. We think it's a part of the panoply of ways that patients will be activated. But when you need a confidant, when you need to see a smiling human face to interact with, there's real advantages to this. The second thing is we're starting off with low acuity clinical situations where the AI is never advising a patient on anything critical. There's always a human in the loop. But over time, some of the stuff we're going to talk to you about with Google is going to allow us to do more and more clinical work. The initial sensors that we're using is just auditory right now, but eventually it'll be visual. And in fact, in this smart city, they're setting up special rooms in the community that you can go in and be fully observed and connected. So we can do gait analysis or depression or labored breathing for asthma. The real magic behind these things, you can't just take a metahuman, back it up to an LLM. There's a complex symphony of agents that are exquisitely orchestrated to create a really human-like conversation. Little things like you have to get a sense of, is the person receptive to what you're saying right now? Or are they in a hurry, or they already know that? So there's all kinds of little clues that make a human conversation human. And finally, one of the things we're really excited about with our friends at Google is to take the next step. So hopefully this isn't too controversial in this room, but I don't think LLMs are really reasoning. I think they've built a model of humans, and they've built a model of the world that humans go around in so that they can predict that next best token. And what we actually need to carry on real human interaction is a reasoning systems. So we've put a lot of work into neurosymbolic AI, combining what the neural networks do really well with what good old-fashioned symbolic reasoning can do well, and combining those two things to make these conversations feel more human and be more effective and be able to handle higher and higher order clinical situations. So we're really excited about what Google's doing in that area. And then finally, this whole thing doesn't work if you don't have the data to infer with. So we're doing as high dimensional as we can possibly imagine, especially in this new smart city that we're working with, everything from multi-omics to environmental sensors in the environment that you're working with, obviously clinical data that's captured, SDOH data, and so making sense of all that so we can infer it and power these metahumans is really important. So with that, hopefully there's a metahuman in your future, constructively somewhere. If you'd like to see more about the technology or see how we're applying it in healthcare, let us know. Thank you.
All right, good afternoon. My name is Jamie Littlejohns, and I am the Chief Executive of Valsera. I'm going to start by giving you two facts I learned recently that blew my mind. The first is that just a ping pong ball's worth of DNA can store the entire world's data. Now, I realize this image is misleading. This is how big a ping pong ball actually is. My second fact is that there are more people alive today than have ever died. Let that sink in. Now put those two pieces of information together and think about how much data there is walking around the Earth today that could unlock the secrets of the human condition. The good news is that AI is accelerating at such a ridiculous rate that it can handle, or very shortly handle, this volume of data. I have to say I was quite surprised when Googleified these slides that they didn't change it to Gemini. So I appreciate not being thrown that curveball. The challenge, of course, is that that isn't seeping through into healthcare. And we've talked a lot today about quite how slow, how inefficient, and how expensive it is to develop drugs. The statistic that is talked about perhaps less is quite how long it takes to scale the use of drugs in the real world. It still astonishes me that it's 4 to 9 years before something reaches its peak impact in society. If you put all of this together, what it means is we have an industry that takes 15 to 20 years from the time that a researcher makes a breakthrough discovery to it being at scale, having impact in the real world. Can you think of any other industry that can survive, let alone thrive, with that pace of innovation? So, what's the problem? Well, I can tell you what it's not. It's not that there's not enough data. Healthcare probably generates more data than any other industry in the world. The challenge, which has already been quoted today in an earlier presentation, is that the vast, vast majority of it, 97% according to this study, goes completely unused. If we're to make a quantum leap with AI, we need to provide it with the data to train the models to move us forward. This is the problem we need to solve. So I'd like to illustrate why that's a problem, and I couldn't come to a Google talk without using an example of a Google company. The leaps forward in visual media and in what we can do with AI have been phenomenal. If we think about how we can generate a video with just a few clicks, with a few prompts, that is indistinguishable from real life, it is remarkable. And the reason that those advances have been made possible is not just because the AI has been able to handle more parameters, but it's because it's been fed a fantastic training set. YouTube has 14 billion videos, but it's not just 14 billion videos, it's 14 billion videos with titles, with captions, with comments. It is an extremely high quality, well-annotated data set that you can train from. If we compare this to our space, to healthcare, there are some fantastic data sets. I happen to have picked the UK Biobank, being from the UK, but this has 500,000 patients in it. Again, phenomenal quality data set. But this is just a tiny fraction of the human population. And given the variety of diseases that we suffer from, the variations in our genetic code, the differences in the way we live and in the way we're treated, if we're trying to find cures for all that range of diseases, we need to have a lot of information, and these single sources are just simply not enough. We've heard it time and again on the stage today. So at Valsera, we think we have the answer. The trick is in combining the clinical side of the world with the discovery side of the world. Valsera was formed by bringing companies together that had both. This is why we work with 80 clinical labs. We've sequenced over 250,000 patients. We run our secondary and tertiary analytics software to help provide cancer diagnoses every day. And the volume that's running through that system is growing at 20% a year. On the discovery side of the house, we help some of the biggest pharma companies to make breakthroughs with bioinformatics. We have 18,000 researchers using our systems every day. But the secret sauce is not just in these two halves. It is in connecting the two of them. Because we have both sides of this equation, we're able to do some things that others are perhaps not. The first is we can go from the discovery to the clinical side. We can help pharma companies and diagnostic companies to bring better diagnostic tests to market that are more likely to scale in the real world because we have an understanding of what it takes to scale genomics practically. The second, and more applicable to today's discussion, is that we can bridge the gap from clinical to discovery. We think that in order to bring data that is usable to research, you need to have a fantastic understanding of both the data itself, how it is structured, its limitations, the complications with it and the variation in it, but also critically the use cases on the discovery side. You need to understand how it's going to create value. And it is in having both parts of that equation that we're able to very efficiently and very effectively bridge that gap from real-world data into discovery. And this isn't all just theory. We've built this system many times over. We are the technology that underpins the Cancer Genomics Cloud, for example. We partner with organizations like PanCan and MMRF to provide their registry data and the tools for that. And we found over the years through doing this that there are 4 critical factors for success. The first and most fundamental one is data security. We have a federated model that means data remains resident with the host, with the generator of that data. And we have a computational layer that allows you to dip in and find what you need. Harmonization is critical to ensure you can compare and combine data across different data sets. And this is where we have tool-assisted methods to make this efficient and effective. Access is critical to make sure that the right people can access the right data at the right time. When you're dealing with 18,000 researchers accessing your data all day, every day, you need to have a sophisticated system of passports and permissions to make sure that people only get what they should. And the final piece, of course, is insights. The data has no value unless people can learn something from it. And this is why we have a series of tools, and we're experimenting increasingly with partners to look at things like chat-based querying, prompt-based visualization, to help researchers look at data in new ways. So that's great, but how does it help us solve that 97% problem? Well, we're tackling this in three parallel streams. The first is we go to individual data generating organizations. We help them organize, structure, and share their internal data, which they might use for their own discovery purposes, or they might choose to share that with others to generate new revenue streams. In parallel, we already have access to over 48 petabytes of public data, which we are working through and harmonizing, allowing us to augment that internal data. And the third is that we have a network of 80 labs that already use our software every day to sequence patients, and we're developing consortium to bring net new data to the world to add to that. Each of these individual steps is relatively small. There are hundreds or thousands of organizations that need to go through this. But if we get this right, we will create the flywheel effect. We will create the search engine for all of this data that allows you to find the patients and the data that are already out there. Now, we're not the only company out there that is trying to create federated data, but we do think we're approaching it in a slightly different way. The first is we don't want to be a data company. We're not trying to create our own unique data source. We believe if we go down that path, we'll run into the same roadblock that everyone else has run into, which is you cap out. We believe that your data should be yours, and that our job is just to help you get the value out of that data. The second is that while software will be a critical component in ensuring that the data can be made available, it is not the only component. You need to have that understanding of the data, that understanding of the use cases, in order to make it really valuable. And this is why we provide solutions combining software and expertise to solve problems, not just software itself. And the third piece is we're in the business of accelerating precision medicine. I think pretty much everyone in this room is in that same business. We don't like to think of ourselves as a supplier or a vendor. We believe our job is to work with you as a partner to help you accelerate on your journey. So if you think you have data that might be valuable that you want to make available, come and talk to us. If you want access to data that you know is out there but you're struggling to find, then come and talk to us. Or if you have technologies that you think can help accelerate this journey, then come and talk to us. Together, if we organize ourselves, we can crack this problem. So I'll leave you with this final thought. Imagine a world where there's a patient with a rare disease. They're in front of a doctor, and the doctor's never seen this patient before. They've never seen this disease before. No one in their department has seen this disease before. They don't know where to go with it. We've heard many examples today. There is a future where a simple question, like how many patients are there like this, and what's the best way to treat them, can be answered. I don't believe that future is too far away. The technology already exists to do this. We have it. The data already exists today. It is out there. The problem we need to solve is one of human organization to connect the dots. And that's the problem we're trying to solve. So thank you for listening, and please do come talk to us if you're interested.